This is presentation number 13 for appendix and ileocecal region, prepared by Prof. Sharaf and revised by Prof. Hani Sami. This is appearance of a Cecal diverticulum, lined-ended tube within a small intestinal series with an interolus inside, something calcific. So this is the Cecal, and this is the interolus in the plain film seen as calcification in an odd site, not used to see it in mesenteric lymph nodes across the abdomen or along one of the ureters or in the pelvis as in ovarian and uterine fibroids. So this is away from the whole of this well known, and the gallbladder is high up. So again, not a gallbladder. It could be an appendix, could be a Cecal's interolus, because it is a big size relatively than that of the appendicular stones. Ileocecal disease, when we see coned secum, and filling defects in the region of the secum. What should be the definition? Crohn's disease, lymphoma, TB, and cancer. Again, Crohn's disease, lymphoma, TB, and cancer. You should add appendicitis and interstitial. So, Crohn's, lymphoma, TB, and cancer, plus the famous appendicitis and ileocecal interstitial. These changes these disease processes can produce some changes at the ileocecal region and result in a coned secum or multiple filling defects at the region of the secum, or a retracted secum, contracted secum. Here it is. This is the appearance of the secum, and this is the appearance of the ileum. This can occur in TB as ileocecal TB, where hypertrophic type of TB can produce such large masses filling the secum, obliterating its lumen, and the terminal ileum is on 90-degree angle with the secum, not as usual with 45 or 30 degrees angle. And there is definitely, if you look at here, barium enema is going and filling the secum and then filling into the ileal loops. Here this cone is again could be due to TB, as we said, could be due to Crohn's, but more commonly with cecal cancer, cecal masses. Cecal masses can cause such a change without affecting the ileocecal region. Also, although here it is patulous, but the changes are seen mainly at the region of the secum, and the appendix can be visualized. So it is something localized at the region of the secum, could be carcinoma. But here it is a diffuse process. Diffuse processes are mainly inflammatory. The T-shaped relation between the secum and the ileum, and the presence of multiple irregular filling defects along the outline denote an inflammatory lesion, mainly TB. Here is intersusception, and this is affecting the ileocecal region. It's not seen, and we have a lot of things inside the hepatic flexure. This is the masses of the intersusception, and this is the target sign of intersusception. This is ileocecal intersusception with obliteration of the secum, which is accommodating small intestinal loops and seen in upward position. In appendicitis, you might find this indentation due to edema of the appendix and swelling, or you would find such a thing which is called appendiceal with very appendicular inflammatory changes. A tubular structure at this right iliac fossa could be an appendicitis, but if lower down, it should be correlated with the region of the tubes in female, and diverticulitis in both male and females. Here is the secum. The secum is the region where a large tumor is seen, filling defect with an apple core appearance and shouldering, and this is the terminal ileum. Again, this is the secum. Barium enema reveals a tumor at the cecal base. A cancer was suspected, but surgery revealed that this is appendicitis. So indentations and irregularity of the secum is among the causes which should be differentiated is the intersusception, as we said, and appendicitis. And the differential diagnosis of lesions at the iliocecal junction is TB, Crohn's, and cancer. This is appendicular or appendiceal diverticulosis, in which you can find diverticuli in a long appendix. Long appendix is a sign of appendicitis. Here is the lid shot appendicitis, where it forms a lot of calculi. Appendicitis can present with a dynamic ileus. Appendicitis or neglected appendicitis can result in a pelvic abscess with relative narrowing of the region of the sigmoid, appearing as a tumor in Douglas pouch, indenting the colon. Chronic appendicitis, only a portion of an irregular appendicular lumen is visualized. This is a part, this is a irregular lumen, only a portion is visualized. In a patient with chronic pain, the CT in another pain shows a right lower quadrant tumor-like process, which could be a tumor, could be appendicitis. So appendicitis can show obliteration with mass effect and soft tissue tumefaction with air, or it can show in CT as soft tissue tumefaction, and the differential diagnosis is a tumor. Extraperitoneal appendicitis and abscess. The abscess may perforate or may be extraperitoneal in location, or it has an access to the extraperitoneum, and thus if an abscess occur, it will involve that extraperitoneal region and bulge posteriorly into the gluteal region. Extraperitoneal appendicitis. Now, appendicular mucocele, this sausage-shaped appearance. We have a cystic structure, and cystic structure has a long differential, but if we can correlate it with the secum, an abscess should be suspected. A needle puncture under ultrasound guide that reveals gelatinous material, that's an inert area, or what we call a mucocele, markedly distended appendix containing gelatinous material. As we said, cecal volvulus can present as elevation of the cecum with incomplete filling, and here is the distended fluid-filled cecum, which is not seen here because it does not fill with barium. It is filling this area, it is pushing this up. This is a cecal volvulus. Here we can find that in this 70-year-old woman with acute presentation of right-sided abdominal pain and elevated white blood cells, that the distal iliac lobes are pushed toward the middle line. the distal iliac loops are pushed towards the middle line. There is gastric dilatation. A soft tissue mass is noted here, soft tissue tumefaction. Density is not at the right iliac fossa, and there is absence of the cecal outline. The cecum could not be traced to the right iliac fossa. So the small intestinal loops are pushed toward midline. The stomach is dilated, and there is soft tissue tumefaction at the right iliac fossa. Here is the CT, coronal and axial, which you can see that there is a large mass-like tube with tubular structure inside, and some gas bubbles are seen. So tubular structures containing gas and are confined to this area should raise the possibility of internal herniation. There is herniation of small bowel loops lateral to the cecum. The herniated bowel loops are dilated, fluid filled, shows stranding at the adjacent fat. Stranding of the adjacent fat means these small perpendicular lines seen. It's called stranding due to perilesional edema. Perilesional edema. The possibilities include necrotizing colitis. The possibilities include appendicitis, cecal volvulus, or the famous but rare pericecal herniation with obstruction, strangulation of the herniated small bowel. Mind you that there are some stations for pericecal for the hernia, internal herniation. One on the right side of the paraduodenal region, and one is at the left side, left paraduodenal region, and the third one is a cecal herniation, pericecal herniation. So now you know 3 sites for internal herniation: right paraduodenal, left paraduodenal, and pericecal, and all of them have such an appearance, an area of crowded loops together, filled with fluid, delineated with minimal air, and are showing the tubular structures of intestinal loops at an odd site, abnormal site. But first, exclude that this is a bag of pus of abscess or bag of cecal volvulus or necrotizing colitis, because there is air near to the walls. Pericecal hernias involve an iliac segment protruding through a defective cecal mesentery into the pericecal fossa and extending downwards into the right paracolic gutter. 4 peritoneal recesses are seen in the pericecal region through which the hernia can occur: superior ileocecal, inferior ileocecal, retrocecal, and paracecal. And these account for up to 13% of the internal hernias of the abdomen. Clinical symptoms related to pericecal hernias are usually reported as recurrent episodes of intense lower abdominal pain that are sometimes difficult to differentiate from appendicular pain, but a recent review stressed the high incidence of occlusive symptoms in pericecal hernias, obstruction. Urgent surgical intervention is needed to prevent strangulation, which is responsible for high mortality. According to a study, mortality for pericecal hernias was as high as 75%. Thank you.